Hi, and welcome to this presentation on disinhibited social engagement disorder. My name is Carrie Wehling. So off the bat, this is an attachment disorder. Before the 5th edition of the DSM in 2013, it was just considered a subtype of reactive attachment disorder. And in 2013, they decided to give it its own diagnosis because there was a separate disorder. It was a separate disorder because of its presentation and the interventions required to kind of fix it. Behaviors mostly in children. It's not to say these can't have lasting effects into adulthood. It would just be considered a different diagnosis then. So behaviors in infants, you would see these kids go with any caregiver. There's no sense of stranger danger. They crave attention and physical contact anywhere they can get it. Same behaviors in toddlers. They lack social boundaries. They're overfamiliar with strangers. They might leave with a stranger, sit on a stranger's lap, give hugs, overshare information if they're verbal. Doesn't check in with a caregiver to see if their behaviors are appropriate. And then in school-age children, we would see an inauthentic expression of emotions, still overfamiliar with adults, and attention-seeking behaviors. These might be the kids on the playground, just making loud noises just to get the attention of anybody they can. And then DSED behaviors in teens, they have problems forming relationship with peers, teachers, coaches, pretty much anybody in their lives. And the ones they do manage to form are pretty superficial, and they continue to be indiscriminate towards adults. The causes of DSED are pretty simply exposure to childhood trauma, maltreatment, and or neglect, as well as inconsistent or unresponsive caregiving. Social deprivation after the age of 6 is found to be predictive of persistent DSED beyond adolescence. And the consequences, you'll see why is this such a problem. They will begin to engage in risky behavior. They'll go with strangers. They'll put themselves in dangerous situations. They have problems with authority, and they are going to be at an increased likelihood of substance use and abuse. The incidence pretty small in the general population, 0.9 to 1.4%, but that number grows to 16 to 52 in institutionalized settings and 15 to 40% in foster care. Interestingly, the research has shown that there's a 72% association between DSED and another psychiatric disorder, ASD, that's autism spectrum disorder, at 47%. And then ADHD, oppositional defiant disorder, and then conduct disorder. So in order for a diagnosis, you would have to see at least 2 of these behaviors that persist, but also in the setting of the childhood trauma, maltreatment, or neglect. Also, these children are more likely to present with impaired cognitive and language, motor, and socio-emotional development. So interventions for social workers, the very first one, the gold standard, this one, nothing else will work if you don't kind of do this one first, and that's environmental modification. You have to provide some kind of improved caregiving that is consistent and responsive to establish a more secure attachment with that child. Thank goodness we don't have a lot of institutions anymore in developing countries, but for children living in an institutionalized setting, it's just finding adoption or foster care placement as soon as possible. And this intervention was kind of informed by a huge project called the Bucharest Early Intervention Project. Unfortunately, there's a humanitarian crisis in Romania, and kind of the only silver lining to come out of it is the fact that they were able to inform the research on attachment disorders and found that a lot of these kids developed disinhibited symptoms because their caregiver to child ratio was only 12 to 1. So they were just looking for those attachments anywhere they could find them. In fact, they found that 42% of children living in these Romanian orphanages had some of these behaviors of DSED, as compared to 18% of the community reared children of Romania at the same time period, including home-raised and foster care raised kids. This study found also that 74% of community-raised children demonstrated secure attachments, while only 19% of institutionalized children had secure attachments. 65% had disorganized attachments in the orphanages, and they found 13% had so little attachment to a caregiver it was unclassified. But they did find that if you take that child and place it into foster care prior to that 24-month developmental kind of stage, they showed a greater capacity for complete recovery of DSED symptoms throughout their childhood. And the study also found that sometimes the social dysfunction characteristics of DSEDs subside just as children grow older and interact with their peers. Sometimes the peers will kind of shape that connection, tell them what's appropriate and not appropriate. And the researchers found that that can be helpful with those impulsive, the peers are kind of shaping the child in a way that the adults failed them. So I found a lot of other interventions that work for DSED, but the second one I really liked was filial therapy, or child-parent relationship therapy. This incorporates expressive therapies such as play, music, and art between the caregiver and the child to build the self-regulation skills. And this is in conjunction with an environmental change, and this might be the environmental change, just bringing the parent in and watching how they interact with the child and giving them tips, watching a play session, have the therapist give them tips and tricks, and just kind of ask them to incorporate just more one-on-one time with this child. And it is a level A intervention, a lot of empirical studies. It's been around since the 60s, as you can see, developed by this couple that just felt like watching a child be able to express themselves through music, art, and play is going to show you more so than sitting them down and just talking to them. Incidentally, one of the other interventions that I found, it was a level C because there's not a lot of work on it, but it's worth mentioning because it include pet assisted therapy, which was showed really promising results for kiddos that are kind of wary and suspicious of the traditional kind of therapist child situation. So another kind of the pharmaceutical side, and I know we weren't covering this too much, but if you're a social worker and you see these kiddos come in, there's not really anything you can prescribe or suggest they get on for attachment disorders. It's all managing the symptoms. So if they have the co-occurring disorder like ADHD, following that medication regime for ADHD is going to help out your DSED symptoms as well. All right, and so some final thoughts. Doing the research for this, it is relatively new. 2013 means it's a little over a decade, and some of the evidence-based studies were just kind of were they right to include this in the DSM as a separate diagnosis? And so you have to weed through all of that kind of noise to get to these studies that actually approach DSED. And a lot of them are just treating attachment disorders in general. And you're just going to kind of treat the symptomology of whatever your kiddo is presenting with. A lot of the DSED kids, it's going to be impulsivity. And I have, so just co-occurring psychiatric disorders, they're going to be treated, better outcomes if you treat the symptoms. And I was really glad that I got this disorder because it involves kids and they're not my wheelhouse. I work with elderly, so this was a challenge and it was great. I really appreciated it. Thanks for listening. Bye.